அதுல போய் என் வீடியோ ஆன் எனக்கும் தெரியுது. வீடியோ ஆன் பண்ணிருங்க. வீடியோஸ் நோ.
Okay.
Okay, now how do I see the slides?
Can somebody present? I will talk in something.
Yeah. Okay.
Hi, good evening, everyone. I'm thrilled to welcome you all for today's informative webinar on prerequisites for management of infertility. I'm Shabnam, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today's evening, Dr. Pujalaksmi. Dr. Puja is MBBS, FIDM, FGO, DRM, Germany. Dr. Pooja is an obstetrician and gynecologist with over 7 years of experience in women's health, infertility, reproductive medicine, and aesthetic gynecology. She has trained at reputed institutions in India and abroad, including an advanced diploma in reproductive medicine from Kahl, Germany. She has worked with leading hospitals such as Apollo Fertility, Cloud9, and MGM Healthcare, and is currently practicing at Lakshmi Clinic, Anna Nagar, Chennai, offering both in-person and telemedicine consultations. Her approach combines clinical expertise with compassionate care to support women across all stages of life. Over to you, Dr. Pooja.
Thank you so much, Shabnam, for the introduction. Very good evening to all of you. So just can you confirm that my audible and my video is clear?
Yes.
And yeah, and my slides are also seen.
Yeah, that is also visible.
Okay. Yeah. So today the topic that we are going to discuss is about the prerequisites for management of infertility. So as we all know, infertility is a booming problem that is happening right now. And I think as doctors, right from MBBS to specialists, all must come across certain infertility patients in your practice. So how to approach a patient while they come walking to your clinic, and what are the prerequisites to come to a diagnosis that this patient is or this couple is infertile. Okay, so that is what we are going to analyze through this presentation. So, the definition for infertility that is given to us is that there is a failure of the couple to conceive after 1 year of unprotected regular intercourse. So that is the term that is given to infertility. So if somebody comes to you with 6 months of infertility and says that 6 months of not conceiving and says that, okay, we have not conceived, so let us go for some investigations. Two things are into consideration. One, have they had regular intercourse? Are they cohabiting together? They're living together in the same household or they're living apart? And if their age is more than 40 years in case of a male and more than 35 years in case of a female. So these three considerations are exceptions to this 1 year period. So somebody who's coming within a year, if these three exceptions are there, we can go ahead and do the fertility workup immediately. But if they aren't, they are still not coming under these three categories, then we can wait up to a year to diagnose fertility. So primarily, there are two types of infertility, which is primary and secondary infertility. So primary is when, as a couple and the female has never had a positive urine pregnancy test or never had a conception as such till date. Whereas secondary infertility is something where the couple would have had a previous live childbirth, And this is the second time they are attempting to conceive, and they are unable to do so. So that is when we call this as secondary infertility. So when we come to the prerequisites, what all do we need to assess to come to a conclusion and diagnosis and plan for the management of the couple is, you have to take a comprehensive history, do a physical examination of both the partners, a baseline investigation, and a specific workup for the male and female partner, and diagnosing what is the root cause behind the infertility, and then going ahead for the further management. So, as I said, we need a very comprehensive history taking, right? How we take a history taking in medicine slightly differs from how a general gynec history taking is. Fertility has little more additions to it. So while doing the history taking of the female partner, age is a very important consideration, because we are all aware that an advanced maternal age is going to give us a reduced live birth rate outcome, reduced chances of fertility. All these things we must consider when it comes to age. And occupation, as in general, any occupation which is stressful, there are night shifts, all those things which can lead to hormonal imbalances needs to be taken into consideration. Going to the menstrual cycle, age of menarche, if there was any precocious puberty or any delay in attaining menarche, the regularity of cycles, if she's having a regular menstrual cycle, what is the duration of cycle? If it is regularly 3 to 5 days, or is it going beyond 7 to 8 days? If there is any dysmenorrhea or passage of clots associated with the periods. Coming to marital history, as I said, to diagnose a couple as infertile, we need a period of 1 year. So duration of marriage is very important. So if they are married for more than a year and they have not been able to conceive, that is a root cause that this duration is being applied to for trying for fertility. And consanguinity, whether they are grade 1, 2, or 3 consanguineous, or it's a non-consanguineous marriage. So consanguinity is going to again give us idea if there is any genetic inheritance of any diseases that's happening within the couple, because they belong to the same bloodline of the family. And as I mentioned earlier, cohabitation. A lot of patients come to me saying that my husband is in the UAE, they're abroad. I live here. He comes and visits me for 2 to 3 months, and then he goes back. So that we will not consider as a entire period of trying for a baby, because they have not been cohabitating together, because they're living apart and they've hardly tried 1/4 of the duration of what we recommend. So cohabitation also needs to be taken down in the history. And if they had used any contraceptives, so initially couples do not plan a baby in the initial first 2 to 3 years of marriage, and they try to use some mode of contraception. If they had used any barrier method, or if it has been a contraceptive pill or a device, we can take that also into consideration for delay of fertility. So then going ahead to an important part, which is the sexual history of the couple. So how frequent they are in their intercourse, if there is any history of pain during intercourse, or burning or irritation following intercourse for the lady, and if there is any usage of lubrication. So lubricants also play an important aspect in the history, because a lot of these commercial lubricants that are available, the non-medicated ones, have a spermicidal effect. So they might have been continuously using these lubricants without knowing for a fact that they have been detrimental to their fertility. So that also needs to be taken down in history. And obstetric history is pertaining to secondary infertility, where the patient is already having a child And then we assess what was the mode of delivery, when was the last childbirth, how much of duration of trying is there between the first child and the current situation, and if there is any history of DNC being done, abortions, or even in the case of a previous abortion, if it had occurred due to a history of cervical incompetence. So those all are giving us a fact about how to deal with the current situation. When it comes to past medical history, generally we ask in our medical and gynecological history also about hypertension and diabetes, bronchial asthma, epilepsy. And the important ones are thyroid disorders, because hypothyroidism among the hormonal disorders is also a cause for delayed fertility. And if there was a history of pulmonary or genital tuberculosis, was she on any anti-tubercular treatment? And what was the duration of her treatment? Did she have any relapse? Did it affect any other system? All these things are to be noted. And of course, PCOS is the leading cause for infertility as of now, because the female factor, PCOS is a very, very important disorder. 1 in 5 women walking into our fertility clinics are diagnosed with PCOS. So the main problem being anovulatory cycles, which are leading to no follicle being released, and there is no fertilization happening in these women. So it is our duty to let them know that it is a treatable form of infertility, and where we can induce the cycles and produce ovulation and monitor the ovulation to produce a positive outcome out of this, and it is not to be feared of. And the other thing is hyperprolactinemia, again a treatable cause of infertility. So again, hyperprolactinemia is going to give you anovulation. So simple cabergoline is going to help us reduce the prolactin levels and produce ovulation. And if there was any history of previous infertility treatment, if she has been on multiple IUI cycles, if she has done any IVFs, or if she has just done any ovulatory induction with certain drugs, that history also is important to us to know which drugs she is responsive to and which she isn't. And past surgical history, if she has undergone any pelvic surgeries, uh, and if she has any previous cesarean sections. Diagnostic hysteroscopy or laparoscopy has been done to just check the condition of the uterine cavity and the tubes and ovaries. And if in case she had a previous conception and it was an ectopic, and one of the tubes have been removed for the same. So that means currently she will be having just one functioning tube. So that is an important history that's going to help us provide her better care when we form her a fertility protocol. And if there was a family history of infertility or cancers, diabetes, hypertension, or hypothyroidism, and the important family history that is indicative of infertility is the age of menopause of the mother. How do you think this is going to help us? So we are seeing another condition called premature ovarian failure, where the woman is not having any ovarian reserve left behind, meaning she will not be able to ovulate and produce eggs further, even if she's not at the age of perimenopause or menopause. She is still unable to produce eggs by herself or ovulate by herself. And that, when we ask the history whether her mom also had attained menopause at an earlier age, it could be positive, meaning her mother also had a history of premature ovarian failure, but must have had her much earlier in our in a younger age than her, because she might be within 35 years, but still cross the duration when her mother would have been in the fertility window. Going ahead with the general examination of the women, when she walks into our clinic, our nurses are going to take the vitals and the height and weight. So BMI is an important factor, as most of our women who are hypothyroid or PCOS belong to the higher BMI range, and that is again a cycle which is going to produce an ovulation. So, and PCOS is also going to show us signs of hirsutism and alopecia and all those things, which can be just assessed when the patient walks inside. And if there is any thyroid enlargement or galacturia pertaining to hypothyroidism or hyperprolactinemia.
I'm sorry to interrupt you, Dr. Pooja, but the candidates are saying like, can the slides be in bigger size because they are not able to see the properly,
Okay,
as yours as well as the slide is like this visible. So
okay.
if only the slide will be available on the screen, because your video is already visible at the top. So
Okay,
yes, if it can be
just
done.
give me a second.
Sure, sure. Yes, doctor, it's fine now.
Better? Yeah, okay.
The font size you can reduce. The slide is visible.
Okay. Fine now?
Done. Thank you.
So, as I was saying, going ahead with the systemic examination, we are looking for the enlargement of the thyroid gland, if any thyroglossal cyst or nodules are seen, breast for any galacturia, and general examination of the abdomen and the secondary sexual characters. And pertaining to the pelvic exam, I'm hearing some background noise.
Just a minute, doctor. I'll mute.
Yeah. So pertaining to the pelvic examination, we look for any ulcers or any pustules seen in the vulva for potential infections, and the pervaginal examination, and to look for the uh, position of the uterus, the fornical fullness, and if there is any cervical motion tenderness present on examination. When it comes to male partner history, it is again like taking a second patient's history now. So, when we assess a fertility couple, I always advise them, don't come alone, come as a couple, so that the history and examination is done together. And then after the investigations and a couple of bloods, we come to conclusion what is the factor that is contributing more to the fertility, whether it is the male factor or the female factor. So it is difficult when one partner arrives separately and the other partner separately arrives, and then it is combined to come to a conclusion, and we explain them individually as well. So always recommend a fertility couple to walk in together at the same time. And let's go into the male partner history, where the age is a factor, but not as alarming as the female side, because female, we are very much aware that maternal age increases the chance of infertility. In males also, currently we are seeing that is happening, but still they have a good amount of sperm production even in their 40s and 50s, but it is coming down as we are seeing that males are also subjected to a lot of occupational hazards, and they are also undergoing a lot of hormonal issues. So, and these are the main important points that we need to check to point out that this particular factor is affecting their fertility. So, any exposure to heat or toxins in their workplace, any history of trauma, either in childhood or in adult age, and if any surgery or infection has been done for the same, and about their sexual history, history of any undescended testes, if any corrective surgery has been done or not, any genital trauma or surgery, systemic illnesses, exposure to toxins or radiation again from their workplace. So, past surgical and medical history, again, diabetes, hypertension plays a role, because it is also going to hinder into the hormonal pathway. And if they had a tuberculosis and it had affected the testis, if there was a TB orchitis which was prominently present and he was on anti-tubercular treatment. Thyroid disorders in males also hamper the sperm production, any sexually transmitted infection. And there is an important aspect where we check in if they're having any psychological dysfunction or any psychiatric illness like depression, because it is going to affect them directly into the erection and ejaculation phase of intercourse. And if they had any physical deformity like hydrocele or hernia and it had been surgically corrected, or if it is still present, any orchidectomy done, or any testicular biopsy had been done earlier. Similar to the female history, if there was any cancer or infertility pertaining to their family, and coming to personal history, we all know that smoking, alcohol, and all these substance abuse is directly linked to reduction in number of sperms. So, any history of that pertaining to personal history. And when it comes to the sexual history in the males, where the erection and ejaculation is able to be produced and sustained by the male has to be understood. And similar to the females, if they had used any lubrication, and if they are not aware of the spermicidal effects of the lubrication, we need to educate them. Male partner examination includes the male external genitalia examination. Again, higher BMI also is detrimental to sperm production. And we assess the scrotum and know the testis volume. And to see if any prostatic inflammation is there, we do a digital rectal examination. To complete it with, we do a epididymal examination to see if any obstructive cause is there and which is producing some tenderness in the epididymal area. So the history part is over as of now. There is some panel that we do commonly to both the partners to assess a baseline to see what is their basic investigation. So CBC, thyroid function test, prolactin, sugars, and ECG is done for both the partners. and the infection panel of HIV, HPSAG, HCV, and VDRL to classify if they are high risk of infectivity group of couple, or they do not have these infections prior. So the coming to the specific workup that we do for the female infertility. So the primary mode of investigation in female is imaging. So we do an ultrasound abdomen and pelvis to note the structural, macro anatomical structural form of the uterus, ovaries, and the tubes. So that is giving us a picture that there are no pathologies like endometriosis or adenomyosis or PCOS for that matter, or if there are any endometrial polyps, or if there are any Mullerian defects of the uterus, like uterus diadelphys, bicornuvate uterus, unicornuvate uterus, septal uterus. All these things, a preliminary ultrasound will give us a basic outline that what we are dealing with, or if this is the particular cause from the female factor that is hindering her fertility, is assessed with an ultrasound. Then picturistically, we know that now, okay, her uterus, ovaries, and tubes are fine, or any pathology is present. That is also pointed out at the ultrasound. Now we need to check for the ovulation of the patient. That is done by a mid-luteal phase progesterone, which is taken in the blood by day 21 of her cycle, if her cycles are regular. So that is going to give us, even if the regular cycles are present, whether there is ovulation occurring or not, that is assessed with the progesterone. And now we know that her ovulation is also okay. Then what else can we assess? Her tubes. Even if she is able to ovulate, whether her tubes are healthy enough to pick up the egg, make it fertilized, and then send it to implant into the endometrium, needs to be assessed. For that, we have multiple modalities of assessing the tubal patency. So tubal patency is a very important test, because most of the times we just do an ultrasound and we assess the ovulation. But what brings it together is the tube. So that needs to be checked prior to starting any infertility treatment. So we do either a HSG or a SSG. HSG is where the imaging modality is an X-ray, and SSG is the imaging modality is an ultrasound. So two different modalities are used, and either a contrast media or saline is infused into the uterine cavity, and the spillage of the contrast or the dye or the saline into the peritoneal cavity is captured either by the ultrasound or the X-ray, and that image gives us an idea whether both the tubes are patent. So a higher modality of investigating the same is a laparoscopy and chromoperturbation, where laparoscopically the tubes are assessed for spillage of the dye into the peritoneal cavity, and made into a diagnosis that the tubes are patent. And the uterine cavity is also visualized at the same moment through a hysteroscope. So now we have an idea what is the structure of the uterus, how the ovulation is going on, and whether the tubes are patent. But if the current ovulation is fine, will she be able to produce ovulation for the next 6 months to 1 year? That we can assess only through ovarian reserve testing. Ovarian reserve means that the ovary's capacity to produce eggs at that current maternal age, if she is able to produce eggs. So in her reproductive period, how much of ovarian reserve is present is assessed through serum AMH, which is again a blood investigation. and something called an antral follicular count on day 2 of her ovulatory cycle. If she is able to produce few follicles in both her ovaries, the number of follicles that are assessed on the day 2 or day 3 of her cycle is termed as antral follicular count. So again, now we know the uterus is fine, ovarian reserve is fine, she is ovulating, the tubes are patent. And the last bit, that is the least contributory factor actually to the fertility, is the hormonal profiling. So as I said, thyroid function and the prolactin hinders the ovulation, so that can be easily corrected to produce healthy ovulation. And again, serum FSH, LH, and estradiol on day 2 gives us a idea how the hypothalamic pituitary ovarian axis is functioning for the woman, and there is no major break in the functioning of the HPO axis. So, excuse me. You can see here there is a pathological picture of uterus where you can see polycystic ovaries, endometriosis, fibroids, polyps, Mullerian abnormality where uterine septum is present, multiple adhesions around the ovaries. And one side you can see the healthy tube, whereas the other side there is a blockage of a uterine tube. And in the cervical region, you can see infection. So these are all the various pathologies that needs to be addressed to be corrected to enhance her chances of having a baby. So when it comes to the male side, we did a history and examination. What is the workup that we do for a male commonly? So imaging is the last modality when it comes to male, whereas in female, it is the very first modality that we use. So semen analysis to know the volume, count, motility, and morphology of these sperms is very, very important. And it gives us a clear picture how much of a male factor is contributing to this couple's fertility. And the hormonal profile, FSH, LH, and testosterone, to know again there is no hindrance in the hormonal axis. And there's something called a sperm DNA fragmentation test. And finally, to note if any gross anatomical pathologies are there, we do a USG of the scrotum along with a Doppler. So I will be explaining that in detail quite quickly. So when we do the semen analysis, the latest WHO guidelines gives us this value to have a cross check with the patient's values to give various diagnoses like teratozoospermia, azoospermia, OATS or oligoacinoteratozoospermia. These are various terms we give when there are defects either in the count, motility, or morphology. So normal semen volume must be more than 1.4 ml for it to be adequate to be analyzed. And the semen concentration should be more than 16 million. And the semen number per ejaculate is more than 39 million. The total motility is above 42%, and the progressive motility is more than 30%. Non-progressive about 1%, and immotile is about 20%. So vitality and normal forms. Normal forms is pertaining to the morphology. So morphology more than 4% is a must to produce a positive pregnancy outcome. So here we are seeing under the slide when we do the semen analysis, a normal sperm count, how dense the sperms are under the high power field. Whereas when there is a low sperm count, there are very few sperm seen in the microscope. And when it comes to the morphology, you see a very normal sperm with a normal head, body, and tail, whereas the abnormal sperm with a head defect and a coiled tail is seen on the abnormal side. And when it comes to morphology, there is a fast forward progressive motion of a normal motile sperm. Whereas when it is twisted, the head is twisted and the tail end is also into very spiral mode, which does not produce the normal fast motility that we expect out of the sperm that is going to fertilize the egg. So these defects, if they are larger in number than the recommended values, then a major contribution then occurs from the male partner. And the hormonal profiling, as I mentioned. So in case of FSH and LH, we need a normal physiological ranges like 1.5 to 12.4 in case of FSH and 1.7 to 8.6 in case of LH for the proper functioning of the axis. The hypothalamus, pituitary, and the testis need these normal physiological values to function. Something higher or lower is both going to cause problems. So higher meaning there could be some genetic disorders like Klinefelter's or a mumps orchitis. A high LH could mean a primary testicular failure, meaning testis is going to not produce any more sperms. Similar to what I was telling as a primary ovarian failure, there is a primary testicular failure also. So at this point, it is 100% contributory to the infertility of the couple. And when it comes to low FSH and LH, it could be contribution from both the pituitary and the gamete as well. And when it comes to testosterone, the normal values are between 170 to 720. There's a huge range. So even with given such a huge range, there are cases where there are low testosterone or high testosterone. So high testosterone is very alarming for us because it could mean a tumor or a cancer. And if it is a low testosterone, then again it goes back to the pituitary axis. And prolactin also contributes to the male side of fertility, where high prolactin can mean a prolactinoma or it can be indirectly by hypothyroidism. Whereas low prolactin is not of any significance to male factor. When it comes to the USG of the scrotum and the scrotal Doppler, as I said, in females, the ultrasound abdomen and pelvis is the primary modality of investigation. But when we assess the male, the USG of the scrotum is the last thing that we do because our main focus is on the semen analysis. Even if we get an answer out of it, we are okay with that. We work on that. But when it is still a normal semen analysis, then we go about looking if there is a contributory factor that is affecting physiologically the functioning of the male reproductive system. So this is to detect any varicocele that is present, to assess the testicular size and volume, to detect any testicular masses or tumors. Again, this can be correlated with the testosterone levels. If there are any testicular tumors or masses, it is going to show a really high testosterone, and that can be cross-checked and confirmed with the help of a USG scrotum. and if there is a inflammatory condition like orchitis or epididymis, and then if it is contributory because of TB or any other genital infection, all those things can be easily correlated with the help of a USG scrotum. And then torsion of a testis is a factor where it needs emergency care. And I think the primary modality of investigation for that is a USG scrotum. So again, I was telling about the sperm DNA fragmentation test. So this is a test which is going to tell us about the genetic integrity of the sperm. So this test is going to tell us in a genetic level, in a microscopic level, how much of the sperm is actually going to help us in fertility. So semen analysis, we are just looking at the morphology, motility, and the count. For example, if we are taking a particular sample and we want to assess the number of sperms which are genetically sound to produce a good quality embryo, then sperm DNA fragmentation test helps us. So higher DNA fragmentation, again, it impairs fertility, it impairs implantation, the number of live birth rates, and the embryo development. So this is a percentage which we assess in the sperm DNA fragmentation test. If the DFI is less than 15, it is okay. That is very much normal. They can achieve pregnancy. But if there is 15 to 25% of fragmentation, there is a moderate risk and there is an impact on fertility. Whereas more than 25 to 35% means they are not really going to conceive naturally and they need the help of artificial reproductive techniques. So this is a very important tool that is going to tell us if we keep trying basic methods of fertility treatment, or are we going to go ahead and go to higher modalities of treatment like IUI or IVF. So this determines how much of the male factor is contributing and how fast we have to react to produce a positive fertility outcome. So, as I mentioned, for the female, the USG is very important. And the AFC, the antral follicular count that we assess on the day 2 or day 3 of cycle is going to tell if this cycle is going to be fruitful, if she is going to produce a good dominant follicle, if she is going to ovulate. All these things we need an ultrasound to know this information. So, and again, the pathologies can be visualized, the AFC can be tracked, and any Mullerian abnormalities also can be checked through this. And as I mentioned, the 3 modes of investigations for tubal patency. So HSG is where we inject the dye into the uterus and we see the spillage into the abdominal cavity, and the HSG is noted with the help of an X-ray at the moment of the spillage of the dye. And the X-ray film gives us an idea if she's having a normal patency or blocked tubes or any other tubal pathology that she has. SSG is again done under ultrasound. So it is less painful than HSG. HSG is slightly a more painful mode of investigation since the injection of dye causes some muscular contractions. And SSG, when saline is infused, the patient does not have much of discomfort, and easily the clinician herself can, or himself can do the ultrasound to know if there is spillage into the peritoneum. And laparoscopy is the last modality. In case we are not happy with the HSG or SSG, then we advise for a laparoscopy to combine it all, to visualize the ovaries, to visualize the or tubal patency, and also to do a hysteroscopy to see the uterus, to combine all these three together at one go to see and diagnose and pinpoint where the pathology is. Laparoscopy and chromoperturbation helps a lot. So these are actually HSG pictures, where the first picture you can see that the dye has gone inside the entire uterine cavity. It has come out of the tube and the peritoneum spillage is seen on the sides. So both the tubes are patent. So both the dye has passed through both the tubes and the peritoneal spill is happening on both the sides. When you see the next one, you do see the uterine cavity lining, but you do not see something that you've seen in the first picture, where there is no lining of the tubes. There is no peritoneal spillage. So this is the condition where they have been trying by themselves and they have not been able to succeed, where the function of the tube itself is hindered here. So clearly the diagnosis is a tubal cause of infertility. And the third picture, again, an infection that has happened and it has caused hydrosalpinx, probably a tuberculosis of the genital system. And you can see how the coil tubes and the enlarged sizes of the tubes are present, which are again not physiologically functioning to produce ovulation and fertilization to occur in these tubes. So this gives us another very clear picture that the pathology is pertaining to the tube and we need to address this issue. So again, hormone profiling. If we talk about the hormones of the women, it is another 2 hours. We can talk about the hormones alone. So I just want to stick to the values that we look into the women pertaining to fertility. So as I mentioned earlier, FSH, LH, and estradiol are taken on the day 2 or day 3 of the cycle itself to know the functioning of the axis. So they give us an idea that hormonally she is okay, and these hormones are going to contribute to the ovulation. So that is what we interpret out of it. And AMH, as I mentioned, AMH is the ovarian reserve testing that we do. So during her reproductive period, at one particular point when we do the serum AMH in her blood, if it is somewhere between 1 to 3, means she has quite a good ovarian reserve, and we can ask her to try for the next 1 year or 2 years until this AMH is maintained at this 1 to 3 value. Something goes below 1, then it is an alarming condition for us to act upon faster. And progesterone, as I mentioned, day 21 level of progesterone, if it is more than 10 nanogram per ml, indicates a positive ovulation prediction through the serum progesterone level. So we have given a elaborate history, examination, baseline investigation, and the workup of the male and female partners. So at this point, we'll come to a conclusion what the diagnosis of the patient is, whether it is a primary infertility, whether it's a secondary infertility, whether they already have a live child and they're trying for the second time. And if the factor is a male factor or a female factor, and where exactly the pathology is, whether it is in the male semen analysis or a macroanatomical structure where there's a hydrocele, or if there is a female pathology like PCOS or cervical incompetence, or if there is a endometriosis or adenomyosis. So we can picturistically and through investigations come to a conclusion and pinpoint where exactly the pathology is and form a diagnosis at this point. From where we work up for the management. So basically, when a younger couple walks in with just 1 year or 2 years of trying and they're not able to conceive, we give something called a preconceptional counseling, wherein we give assess certain parameters like AMH, a basic semen analysis, and give an idea about how to do certain lifestyle modifications, know about your fertility window, uh, assess your ovulation through ovulation kits, and then have timed intercourse according to your fertile window. And in case anything abnormal is seen in the investigations, then the possible need for artificial reproductive techniques must be emphasized, because as we know, AMH semen parameters tend to change frequently, and if we end up at a point where we are able to help them, they must take it at the right moment. So, and as a physician, this means they are already emotionally very drained out of trying. And if they come to a diagnosis of primary or secondary infertility, it is up to us to give the right diagnosis and advise the right mode of management at the right time. Timing is very important when it comes to fertility, and that's what I like to conclude my talk with. Thank you so much.
Thank you so much, Dr. Pooja, for this session. We
Yeah.
will be starting the Q&A session. I request everyone to write their questions in the chat box, and Dr. Pooja will answer them one by one. Meanwhile, I'll also be sharing the certificate registration form in the chat box. I request everyone to please fill the form and get your certificates in your mail ID. We can start the Q&A session. So Dr. Nazneen was asking treatment of blocker tubes.
Treatment of blocked tubes. Okay. So when there is something that's happening like tubal blockage, even if they are able to ovulate, the tube will not be able to catch up the egg and bring it into the endometrium. So what we do is IVF, where we take up the gametes separately, fuse them under laboratory conditions, and instill back the embryo into the endometrium. So that is the idea that we are having right now for blocked tubes, because again, to remove the blockage is nearly impossible now. They're very delicate structures, and if once and for all we are confirming through a laparoscopy that they are blocked, there is no going back to reopen the tubes or remove the blockage in any way. So we have our direct modality of forming an embryo and implanting them into the endometrium. So IVF or ICSI is the choice of treatment for blocked tubes.
Dr. Lovepreet is asking, what if AMH is low unmarried?
Is low and unmarried. So we need to know how low it is, whether it is 2 or 1.5 or 0.5 or even less than 0.1. So how low is the question? And unmarried, okay, that means you want to preserve your fertility for the future. So there are certain medications to prolong the process of reduction of AMH, but again, it depends really on how low the AMH is. Something about 0.5, we really don't have time in our hands. We have to act fast. In that case, if you want to preserve your fertility, there is something called oocyte freezing. And if you're unmarried and you're planning for a pregnancy later. We freeze the eggs at your current maternal status. So for example, if you're 25, the eggs which we are going to take up and freeze are going to be 25-year-old eggs. So later on, if you're 30 and you want to get pregnant, the quality of eggs will be much better at that point. So the treatment modality for somebody with low AMH and unmarried is probably oocyte pooling. If it is above 1 or 1.5, we can try medication.
So Dr. Asmina is asking, can you please repeat the criteria, 3 criteria to consider workup for infertility in couple trying less than 1 year?
Yeah, so 1 year, the male, so somebody who's more than 40-year male, who's a 35-year-old female, more than 35-year-old female, and who are not really living together, not cohabitating together, they live apart, and they have no, yeah, that is the criteria.
So Dr. Vishal is asking, in case of FSH, LH decrease, both male and female, what is the next step?
Okay, so that is the entire class. So, how to assess what is the reason behind the hormonal issue? If it is a syndrome like Klinefelter's in case of male, if it is syndrome like Turner's where there are streak ovaries in case of females. So each cause, we need to work upon that and see how if it is a treatable cause, if the hormonal profile cause is treatable, then we can go ahead using GnRH analogs, GnRH drugs. But if it is a non-treatable issue and something that cannot be corrected from our end, then something like donor gametes can be used. The gametes are donor gametes, and they are used to produce an embryo, and then later that embryo is used to produce a pregnancy in the mother.
So
Yeah.
Dr. Dhananjay is asking, can you please elaborate about the chromophin citrate, its timing of administration, its dose, and up to how many days to administer?
Okay. Clomiphene citrate, generally we start with 50 mg. We can go up to 100 mg. But again, clomiphene is a very tricky drug which it produces multiple follicles in an ovulation induction cycle. So we are all sticking to letrozole as of now, which is very safe and is producing really good results and not many follicles at the same cycle. And timing of administration is between day 2 to 5 days of cycle, like from day 2 onwards for 5 days, and mostly in the night. So maximum, I think 5 days is enough. That itself is causing a lot of flare up of multiple follicles. But if the patient is really unresponsive and really not producing follicles, then we can go up to 100 mg. Yeah.
So Dr. Asmina is asking, ovulation induction done using clomiphene and letrozole after day 21 progesterone peaked, still no HCG positive or pregnant. What could be the reason? Male parameters are all okay.
Okay. So again, clomiphene is used, letrozole is used, day 21, meaning ovulation is done, still no HCG, positive pregnancy. Did you check the tubes? Is my question.
So one doctor is asking, what can we do if male partner has oosospermic and female partner is all good?
Okay, azoospermic, then we need to know whether the contribution is obstructive azoospermia or non-obstructive. So something like a structural defect can be corrected through surgery and they can conceive naturally. But something non-structural and it is completely no sperm production even in the testis level, then we can go for a donor sperm.
Dr. Reena is asking, can you please explain how to follicular study accurately?
Okay, follicular study. So, follicular study can be a stimulated one or a natural cycle as well. So, in case you're giving drugs like clomiphene or letrozole on the day 2 and continuing for 5 days, then we ask the female to come around the time of ovulation. So, peri-ovulatory phase around day 10 we start the follicular study. Then it's every alternate day, day 10, day 12, day 14, day 16. So by this time, we expect the ovulation to occur. And again, we do check the endometrium as well if there is a good reaction in the endometrium also. And if there is any uh, good follicle that is developed, and if the follicle has been emptied and there is collection of fluid in the pouch of Douglas, that confirms ovulation in the follicular study. And I think that is the purpose of follicular study as well.
Dr. Amrapali is asking what to do in LUF.
What is LUF?
We have right this only LUF.
Chances of multiple pregnancy in case of 3 to follicles growing in case of PCOD. Yes. PCOD and multiple pregnancy don't go together unless and until you're stimulating the patient. PCOD meaning they're producing a lot of follicles, but none of the follicles are growing to the size required for ovulation. So those are the follicles sitting around the ovaries forming cysts. So they are of no use. They are not producing any eggs out of it. So yes, but when you stimulate a PCOD patient, we must be very careful because all the dormant follicles might start growing together. But again, the quality of egg that is going to come out of that follicle, we do not know. But multiple pregnancy is not really the case in PCOS. It is multiple follicles that actually form.
Okay.
Diet for sperm quality. Okay. Okay. Diet for sperm quality is again a diet that is very clean and not including unsaturated fats. Uh, and there is no particular one wonder food that is going to contribute to good sperm quality. But then, yeah, if then the patient is really anxious and they want something from their side, they want to help themselves, and walnuts and red bananas quite regularly.
Dr. Reena is asking how can we achieve fertility if male factor is same?
Male factor. So again, if it is only a semen parameter problem, we take a time of 3 to 6 months, give few drugs to correct the parameters, and reassess after 90 days the semen parameters. So again, you know that to form one cycle requires 90 days. So after 90 days, we recheck the semen parameters, and if they are fine, and if they have uh, gotten better, higher chances of natural conception.
Okay, so doctor, any recommendation can we give?
Okay, how can we achieve? Okay, male factor is seen. Patient is around 28-year, unmarried, known case of endometriosis, now on Dynogest, and AMH is 0.03. Okay, this is the case, only egg freezing is the option. 0.03 is really, really low. Like, we need to see her AFC of the starting of the cycle, her AFC, if she's actually producing some egg during the cycle. Because with 0.03, we can hardly find 1 or 2 eggs, no? And CA is also a little high. Okay. she needs to really see if she's having any ovarian reserve. 0.03 is really alarming. So to do a AFC on day 2 or day 3 to check if she is producing uh, follicles. And with endometriosis, again, the ovarian stroma will be very much damaged. And for uh, 2 to 3 years with endometriosis, if she's uh, having it for so long, most of the ovarian stroma is also infiltrated by it. So, and that shows on the AMH 0.03. I think at this point, if she's able to produce 1 or 2 eggs and she's able to freeze it, that's a very great thing. But again, we can always go ahead and think about donor oocyte options also. Yeah. Okay. Higher DNA fragmentation can be treated. Not really. Higher DNA fragmentation is an index that is telling, it's like a diagnostic tool. It's not really telling us, it's not really going to help us in management. It's just a diagnostic tool which is telling so much is destroyed, so much is normal, so much is at high risk. So if it is high risk, there is no way to fix the DNA fragmentation. We just go ahead with probably a IVF where we microscopically see the best sperm. So at least we are able to visualize which is morphologically having a good head, which is having a good body and tail. And we are using that to go ahead with the IVF. And something which is more morphologically good and healthy is going to give us a good outcome. So DNA fragmentation can't be treated. It is just a diagnostic tool. Oh, 0.3 is also low. 0.5 itself is very alarming for us, Lovepreet. 0.3 is very, very low. I think with so much of years of endometriosis, her ovaries are quite gone in for that drainage of the ovarian stroma. So you just need to check on the AFC of her cycle. If she's able to produce 1 or 2 eggs, if you're able to really take out and a good quality egg and freeze it, it's really great. But then with 1 or 2 eggs, working on it is also again difficult. And when she forms a zygote, if it is a only a healthy egg is going to produce a healthy zygote. So many factors are there after that. Medicine for endometriosis. Okay, we can start. Depends on again grade of endometriosis. Endometriosis again one big chapter. So depends whether it is the location of the endometriosis, the grade of endometriosis, and how responsive patients are to certain treatments. All those things are there. Is I cannot bluntly say this is the treatment. There are so many levels of treatment for certain up to surgery, not only medicine. So if there is a case of ovarian cystic endometriosis, like we call it a chocolate cyst, we need to laparoscopically remove it. That is the treatment. So why are we treating the endometriosis again? Is just to treat it or is going to enhance her fertility? So again, big discussion is there. Tubal block test done is normal. Previous question, clomiphene. What else to check? Normal, okay. Letrozole. I think you can just okay, with the clomiphene and letrozole, uh how many follicles did she form with clomiphene? And on which day of letrozole did she ovulate? So day 21 is peaked. On USG, how was her picture? Male parameters are normal. Okay. You can even try injectables, GnRH, a combination of letrozole with injectable GnRH in the next cycle. And how many cycles have you stimulated her as of now? Can high movement cause recurrent abortion? Yes, yes. High DNA fragmentation means sperm is not of good quality. It can cause recurrent abortions. I mentioned that. After IVF and implant embryo, what next line of treatment medication to sustain procedure? Okay, implanted embryo, we will give supportive progesterone mainly. And if there are any contributory factors like immunological factors, or she is a case of SLE or some immunological diseases, or she is um, having some hematological disorders, then definitely we need to give supportive medications for the same, but mainly progesterone. It can be either injectable or oral progesterone as well. Day 2 to day 5 taken cycles. Taken 5 cycles and follicular study not done, but day 21 showed very high progesterone. Okay. I think you have to do a follicular study, and 5 cycles of stimulation is too much. We should just do 3 cycles of stimulation with the follicular study. And then if she is still having high progesterone and she is not able to conceive, then try for a HCG injection on the day of ovulation, and then after 33 days check for the UPT. If this is not happening, I think you should shift over to an IUI, because it is going to be next modality, because 5 cycles already she's been stimulated. I think with stimulation and no follicular study, it's not of any use. It's better you do an IUI and follow it up with the follicular study. How to correct high prolactin levels? Cabergoline tablets, depending upon the level of prolactin, serum prolactin, starting at 0.25 up to 5 mg, weekly 1 dose for 4 weeks. Dexamethasone can help. Not really. Not really. You should do a follicular study and proceed to an IUI. Idiopathic ITP. Okay, if she's naturally conceiving and just conceiving with a few drugs and a follicular study, we can not really depend on the progesterone. But when there is an ITP, I think the physician also needs to give an opinion, because he knows her pathology better, and we can work with the physician and form a specialized protocol for her. 37-year-old, AMH is 3.5. Okay, okay. IUI. Okay, Alka, thank you again. 37 years with 3.5 AMH is good. But you have multiple issues like PCOS, dysmenorrhea, and left side block. Okay, dysmenorrhea. Okay. Um, do you have any particular pathology pertaining to the dysmenorrhea? Do you have any adenomyosis or endometriosis contributing to it, or it is only the PCOS and left side block? Semen count of 50 million is okay. Active motility 5% morphology. 5% morphology is okay. DNA fragmentation. I think this count and morphology do not require a DNA fragmentation. Okay. I really want you to have a check if your current right side tube is functional. So for your picture, I would suggest hysterolaparoscopy, which will give us a clean picture of what is going on inside your uterus, your tube, if it's functioning, your one tube, and how bad your PCOS is. And if this 50 million, 5% isn't recent, you can do a recent analysis and see. DFA can just tell us if there is DNA fragmentation, but with this count, I do not recommend. Only when the count and morphology and motility is very less, then we can go for that. I think we need to reassess you with hysterolaparoscopy. And then if the only tube is functioning, then go ahead for an IUI. Small size follicle, 11 or 12. Okay, 11 or 12 does means it's not a good follicle. We need at least 18 to. Do you mean 11 or 12 in size or number of follicles? How metformin works in infertility? Okay, metformin is primarily given to control the insulin resistance in PCOS. So it kinds of cleans up your PCOS and helps to actually make the ovary function better. But again, metformin is like it's like an adjuvant treatment. It is not the primary treatment. So when PCOS is in the flare-up stage, it's really producing multiple follicles and not really contributing to ovulation. And patient is having symptoms of insulin resistance. At that time, it's an adjunct to help with the ovulation. It is not a primary mode of treatment. Okay, after ovulation induction, if follicle does not rupture, what do we do? Okay, we can, as I said, follicular study has to be done from day 10 onwards. So we wait up to 16, day 16, day 18, even sometimes up to day 20, certain people have delayed ovulation. If at all it does not rupture, and if it is a stimulated cycle, we do give HCG injections to induce the ovulation. Undiagnosed adenomyosis. Again, you need to diagnose it properly with the first with an ultrasound to see if it is contributing to the infertility. Unruptured follicle after HCG, what to do? Do not continue with that cycle. That means that it is not a healthy follicle. and it is HCG is not helping even after 36 to 48 hours, means it's a failed cycle, and this is not going to help us in any way, this cycle. Tubal block due to genital TB means after taking ATT, fertility achieved. Okay. After taking antitubercular treatment, again redo ultrasound, redo HSG. Structurally, if they are okay in the ultrasound, functionally, if the tube is patent through the HSG, then fertility can be achieved. If after TB and there is maximal damage to the tube and it is not of any help to the patient, then there is no point trying to achieve fertility naturally. And in active TB, HSG is contraindicated because we are going to flush out the TB bacilli into the peritoneum. So it is only after she has completed her treatment and there's no relapse and she's completely cured of it, reassess with ultrasound and HSG. Reduced by lifestyle modification. Ovarian cyst, by meaning, do you say PCOS? Javaria, ovarian cyst can be reduced by lifestyle. Do you mean by PCOS? Can dexamethasone help with ovulation along with the clomiphene or letro? It can help PCOS. We are not really using dexamethasone. You can try HCG. 5,000 international units to 10,000 international units to induce ovulation. Dexamethasone is just to not to contribute to any flare-up of changes. It's not going to really help in ovulation. We are sticking on to HCG injections of 5,000 or 10,000 international units. You can try that after stimulation with clomiphene or letrozole for a stimulated cycle. When can we treat it for ATT? Yeah, your primary physician should give a clearance that you have been cured, there is no relapse, all your preliminary TB tests are okay. After stoppage of antitubercular treatment, again give a gap of 3 months and then start. Okay, yeah, definitely. If it is due to PCOS, lifestyle modification is the number one modality of treatment. So, meaning, to be very precise, 10% of reduction of weight from your current weight. 10% of your weight, if it is being able to be reduced, and if you're able to avoid all unsaturated fats in your, saturated fats in your diet, your PCOS is symptoms are going to significantly come down. Leave alone the cysts. The cysts are going to be there. There is if you're going to reduce your weight by 10%, and if your dietary changes are happening, ovarian cysts might reduce and you might start ovulating actually, because in PCOS you're totally into anovulatory cycles. So it can happen, but don't expect something miraculous to happen on the ultrasound that your cysts disappear. They might still be there, but your symptoms will be very much better. Okay. Thank you.
I guess, Dr. Pooja, we are done with the Q&A session.
Okay.
So thank you so much, Dr. Pooja, for this insightful session. On
Thank you.
behalf of everyone, I extend our sincere gratitude to you, Dr. Pooja. Thank you so much for today's session.
Thank you so much, Shabnam. Thank you all.
So I'm pasting the certificate link again in the chat box. Please do fill that. And if you have any further questions or would like more information, you can reach to us. Don't forget to follow us on social media and WhatsApp channel for further updates and webinars. Thank you so much, everyone.
Thank you.